Hi, everyone. Thank you for joining us. I'm Tyler Dukes. I'm an investigative reporter for the statewide investigative team at both the News and Observer and the Charlotte Observer.
Hey, everyone. I'm Teddy Rosenbluth. I'm the science and health reporter for the News and Observer.
Hello, my name is Kira Kimball. I am a certified doula and owner of Minority Doula Agency in Charlotte, North Carolina.
Thank you, everyone, for joining us today. And so, like many investigative projects, it starts with the data. And so we did a lot of work on that. And so my first question is for Tyler. I'd like for you to share with the viewers some of the data that you found and the methods and why this matters.
Yeah, absolutely. So we actually started this project after we were contacted by a journalism nonprofit working on the national level called Muckrock. And what they had actually done is taken data from the CDC newly released about pregnancy-related deaths across the entire country, particularly in states that are able to report these numbers because they're high enough. They cleaned the data and shared it with a couple of news partners, including us. So we took a look at that data, and one of the things that really sort of stood out to us was the degree to which North Carolina was really sort of out of sync with the rest of the country, even though the entire country went through the same sort of COVID-19 pandemic in some ways. There were clearly impacts that were pushing up the pregnancy-related death rate in North Carolina a lot more than the country overall. And so using that data as a starting point, we went to dive a little bit deeper. So in addition to pulling the CDC data and analyzing it back from just North Carolina and across different aspects of what was happening to women in our state, we also looked pretty deep into the state's own death certificate database, on which a lot of this data from the CDC is based, and tried to draw a little bit more out of that to get some questions answered, quite frankly, about why these rates were so high and what about North Carolina seemed to really be out of sync, again, with the rest of the country.
Right. So can you expand on that a little bit, and what you found in your investigation and the data? What are some of like the top 3 reasons, or some of the reasons why like North Carolina is ranking much higher than other states?
Yeah, it's such a good question. It's one we put to a lot of experts. And, the reality is that there is a lot of speculation about why North Carolina specifically is worse than the nation overall, but, little real clarity. And I think we saw some commonalities in the comments that we got from experts about, what is going on in North Carolina. There are higher rates than other states in North Carolina of comorbidities, things like obesity and things of that nature. Also, we have to think about North Carolina being one of the last states to expand Medicaid. And so there are some issues along those lines that we talked to experts about. Also issues of maternal health deserts. These are rural areas where mothers in these places have less access or have to drive further to get the sort of maternal care that can help keep their pregnancy healthier overall. But, the reality is, one of the things that's really tricky about this data is because the numbers are in relative terms very small, and in a lot of cases very dated. We're talking about data right now from the CDC from 2021, so we're almost 2 years old at this point,
Right.
that there really is a lag and a gap in what we can really come to grips with in terms of what we can figure out was really causing the problems in North Carolina versus even comparing to other states or the country overall. So, I mean, one of the sort of takeaways that we came away with here is that experts pointed to a lot of different things, but there really was no one big thing that everybody could point to say, this is why North Carolina is definitively worse.
That's really interesting that you couldn't drill down as to one big thing, that it's so many different things. I'm actually gonna bring Kira Kimball into the conversation. I know that you've been focused on what you can do in your community and with the women and to try to improve outcomes, to try to bring some more access. What do you think about that? Some of the stats that North Carolina is ranking higher, and what you've just heard. What do you think might be done to kind of rectify that? I just was curious as to your thoughts about some of these stats, if you will.
So some of the things that doulas do when working with families is helping them establish care and helping them align with care that is that will support them in what their goals are. And so it's really easy to sit on paper and say, okay, you like this, this, and this, so you'd work really good with this model of care, and then matching you with a provider that fits all of those criteria. The problem is, and Tyler alluded to it, is there are maternity deserts. There are places where we just don't have access to choice and different options in care. And so sometimes you don't get the care that would be best for you. It's the care that's available. And so part of our job is to kind of fill in the gaps. And so maybe they're not getting everything that they desired. Our job as doulas is to kind of to fill in those holes. So they might not be getting the information they need about nutrition and exercise and things that they can do to help prepare their bodies for a healthy pregnancy. And so we provide that information. I think a lot of the problems that stem from this disparity within North Carolina is a lot of the women that enter into pregnancy are entering already not being healthy because they have not had proper care leading up to conceiving. And again, that has to do with the maternity deserts, but that's during pregnancy. If you don't have access to healthcare prior to pregnancy, it's really difficult to go into pregnancy healthy. And those health challenges spill over into unhealthy pregnancy and then into the kind of outcomes that we don't want to have with our children. And so I do see that kind of lag in care that a lot of people don't have insurance coverage, and they're having to make decisions and stretch out appointments, and they're not getting the regular care throughout their pregnancy to produce healthy outcomes.
So just wanted to toss it back to you, Tyler, real quick. You mentioned that there are like these healthcare deserts or maternal health deserts. Were you able to figure out where that is within the state? Do you have any information on that? Like where like greater concentrations of that might be? Is it more in like more densely populated area, or is it more out like in rural communities? Do you have any intel on that?
Yeah, and in fact, the organization called the March of Dimes actually produces quite regularly what they call the Maternal Health Desert Report, where they look at this very specifically. And these areas are where you might expect the sort of rural areas of North Carolina, where women may not have access to the same sort of birthing centers or birthing services. The hospitals are a little further away. And their rationale or methodology for determining where these deserts are often in western part of the state, the eastern part of the state, northeastern, where I'm from, actually, in North Carolina. And so they tend to be concentrated away from places like, for example, the Triangle or Charlotte, where we are a lot closer to those sort of cutting edge healthcare facilities that we often think of that are sort of indicative of sort of urban centers.
Cool. So I'm going to bring Teddy into the conversation a little bit. So Teddy, you focused on a couple of stories you focused on dealt with mothers that, despite their best efforts, they still lost their lives. It was really heart-wrenching, some of the stories that you wrote. Maybe you can talk a little bit about those stories that you wrote and the people you interviewed and what you learned from them, and if there are any additional opportunities available to mother to help prevent these pregnancy-related deaths, or just tell me a little bit about the stories that you wrote.
Yeah, definitely. So I think it's important to talk about with maternal mortality is that this is such a unique public health problem, and that it affects such a wide range of, different people. It's not just low income women. It's not just women living in rural areas, even though those are, certainly factors that can play into it. So it was really important for us to kind of interview as many, families who are affected by this as possible, to kind of get all of these like nuanced stories and figure out all of the different, times when women can fall through the cracks. So thanks to some of Tyler's past reporting, and he mentioned this, the News and Observer has a database of, North Carolina death certificates. So we were actually able to go through that database and figure out, all of the women who had passed away from, a pregnancy-related complication. And so we, reached out to as many of those families as possible. And we were able to connect with a couple, one of the families I spoke with, the Thomas family. This was just, a heartbreaking family of a father who is, now left with 3 children to raise on his own, because his wife of 13 years, passed away, because of COVID complications and other comorbidities. And, she had to go through an emergency C-section. And luckily, the child was fine. But, now he's kind of raising these 3 kids all by himself. So it's just really heartbreaking stories. And then the other part of it that we felt was really important to capture were these near misses. These are women who didn't die from these pregnancy-related complications, but who had really, significant health complications. So we were able to, or Tyler, I should say, was able to get in touch with a woman, Stephanie Wisda. It was a really fascinating story because, she had, every resource available to her. She was a healthcare professional. Her husband actually, was an OBGYN. And still she had, this scary event happen to her. She had a, grand mal seizure during her pregnancy. So I think that really just captures, how pregnancy is pretty universally dangerous in North Carolina.
So what is the disconnect? If someone that has that much access, I mean, her own husband is an OBGYN, and she obviously comes from a family that has, access and resources and stuff. What can we say about what is the disconnect? Can anybody perhaps speak on that? Maybe Tyler, in the data that you've seen, or maybe just what you've seen, Kira, in your own experiences and such. Anybody can chime in first.
I mean, I'm happy to, it's different in every single case, and that's like sort of one of the complicated parts of this issue. But I think there's definitely an issue, especially with, women of color or, just women in general, sometimes like not being listened to in the healthcare sphere. So even if you have all the healthcare access, the quality of the healthcare that you're getting can, not be enough.
Right. Okay, let me just toss it over to Kira, speaking of women not being heard, because a lot of in the story that I wrote, I talked to yourself, Kira. I also spoke to a lactation consultant who runs a company for that. And she's also a healthcare provider. Her name was Rachel Dean. And both of you have suggested that you go to the doctors and you're not heard. You're telling the doctors you have problems, you have some issues, and you're not heard. Congresswoman Alma Adams also started the what she calls the Momnibus bill, to try to bring more awareness to Black maternal health and stuff. Her own daughter and granddaughter had a near miss because she basically said the doctor was just not listening to them when they were having problems. So I guess my question is what can we say about that? Is there a problem with the system, or is it just, women are not articulating their concerns enough, or doctors are just too busy? You want to comment on that, perhaps a little bit, Kira?
Well, it's a very complex issue, and I'm glad you brought up the Momnibus Act. So the Momnibus Act is a bill that's going through that we are still in the process of finalizing, but it hopes to address issues affecting maternal mortality and all other social determinants of health. So like I said, a lot of times we have women that come into pregnancy that weren't healthy to begin with. And so what the Momnibus Act does is address those issues: access to food, housing, transportation issues. And so all of those things affect healthy pregnancies. And so when we talk about maternal deserts where there's not access to healthcare, it doesn't necessarily mean that's only for rural areas. We saw this during COVID when there were some children that had access to internet and could do their online learning and others didn't. And we see these gaps where there's almost two separate Americas, where one can adapt to moving to online and getting care where they're needed, and the other not, and they're really struggling to get basic services. And that's not just in rural areas. We have that right here in Charlotte, where there's a housing crisis. We have pregnant mothers that don't have shelter. We have pregnant mothers that have trouble accessing food. And so the Momnibus Act does address those things, and it also addresses bias within the healthcare system, making sure that our providers are not that are listening to both to mothers and of all races, and making sure that they are heard and that they are centering the patient as being the having bodily autonomy, being able to make decisions, and trusting the mother to know when something's not right, and looking a little bit deeper. And so those are some of the things. It's like I said, it's very complex. There's not one answer, but that's a beginning to really kind of drill down into what factors are affecting maternal health in North Carolina.
Tyler, do you have anything to add from the data that you've seen about why there's such a disconnect that you haven't already answered?
Yeah, I think these points are all great ones, but one thing that I will bring up is something that Stephanie Wisda's husband, Alan Rosenbaum, who's a OBGYN, sort of told us, and both of them sort of underscored in our conversations with them that, as Teddy mentioned, they had access to everything they could have possibly needed for the entirety of this pregnancy. And still, this was a close call that almost resulted in Stephanie's death. And, to hear Dr. Rosenbaum tell it, that is just an indicator that, if they had not had all of those resources at their disposal, this could have gone a very different way. And so that's why he underscores these issues of access, these issues of, dealing directly with other types of social determinants of health. Kira mentioned that. Issues of transportation. Almost every expert we spoke with mentioned just being able to make sure that families can get to their appointments like they're supposed to. They have access to, a vehicle or a driver or somebody that can get them to where they need to go. And so all of these things, like many other issues in healthcare, are so vital to making sure people get what they need to reduce the risks to women and mothers who are pregnant.
Awesome. So just want to bring the conversation back to Kira again in terms of what I wrote about and covered. You had mentioned that some of the feedback on some of the comments were that Black women are often portrayed as victims and such. But I kind of felt like the story I wrote was intending to show that, Black women are weary of the inequity and they're trying to come up with their own businesses. You came up with your own business, and you can share a little bit how that evolution came about, because you saw a need, as did Rachel Dean, as there are tons of networks of Black doulas and Black lactation consultants and such. So just if you can share a little bit about that feedback that you got and what you heard and just, what can be reconciled with that, if anything?
Yeah, much of the feedback that I received were people coming to me in fear. They now had all this information about how dangerous it is to give birth in North Carolina, and they were fearful going through the process. These are women that are already pregnant that are now afraid to deliver. And so we've been doing a lot of work kind of helping them understand the risk, the very real risks and challenges, but also giving them tools and helping them to understand that there are things that we can do to lower their individual risks. One of those things is having a doula on your birth team. A doula, like I said, is not part of the medical team. We are not trained medical professionals, but what we are experts on is birth. We are experts on keeping the patient at the center and helping make patient-driven decisions that are based on what's best for that person, making sure that person's voice is being heard, helping them have a voice in their healthcare decision-making, and helping them understand what information that their care team is providing them, helping them have some option and say in what happens to them. Having all of that power within and keeping that power with the birthing person lowers things like anxiety. It lowers the dissatisfaction rate of coming out of the hospital setting, making sure that they are active participants in their birth. One things that doula do is we make sure that we establish relationships with these families early on in their pregnancy. We build that trusting relationship so that by the time we are in the healthcare facility and we are giving birth, we've already established a trusting relationship. And that relationship is, they usually trust their doulas more than they trust the medical professionals in that room. They're more likely to tell us when they're experiencing some symptoms and not sure if this is something that she can be concerned about, or can they ignore this? Is this normal or not normal? And doulas are often the people that catch things that were missed, and that we're alerting the providers that, hey, we need to look at this symptom a little bit more. This could be something. And so we are part of the team, but we're not part of the medical system. And that kind of gives a bridge into what the patients need in order to feel safe in that environment.
So it's interesting. It sounds like that maybe we need to normalize doula care some more for women and stuff. Another quick question I had, just in case some of the viewers may not know, just the difference between a doula and a midwife, because as you know, one of the women that I interviewed for the story, Karen Phelps, who's a Charlotte-based attorney, I think she heard the alarming stats on the television when she was pregnant, and she kind of took action. And so she got herself both a doula and a midwife. So maybe Kira, you can share, because I'm not a medical professional, and Tyler and Teddy, we're reporters. So maybe you can just shed a little light the difference and, how that could be, additional help for women.
So midwives are medical professionals. Midwives do things like check blood pressure. They operate medical equipment. They are ensuring that the patient is having a healthy pregnancy. They do lab work. They do blood draws, whatever is needed medically to support someone throughout their pregnancy, birth, and postpartum. Doulas are more of the emotional support.
Mm-hmm.
We are the person that patients might talk to when they are feeling fearful, or they have a stressful work situation, or they are experiencing homelessness or food scarcity, or we don't know where we're going to find diapers. What resources do we have in the community that can help us access this? Doulas are really good at finding resources for people that need those things. We provide informational support. So they might go to their appointment and the doctor might say, hey, your blood work looks a little bit unusual. We're going to do some more testing. And then, they do the test and they say, we'll have results in a day or two. That day or two is very stressful for the family. And so that gives them a chance to reach out to their doula, and their doula is kind of giving them more information and answering questions that may not have popped up during that appointment, but they think about later, and the doulas can help them process that information. We are gatherers of information. We do research. We provide physical support. Sometimes you just need someone to come over and sit with you, or to go with you to an appointment, maybe because you're nervous, or maybe you just need someone to come in and tell you that you're going to be okay, and rub your shoulder, or whatever it is. That's more of what the doulas do. We provide comfort, we provide information, we provide access to resources, emotional support. The midwife is more of the medical care, making sure that you're having a safe and healthy pregnancy.
So that sounds really important. That I guess when a woman, as soon as a family finds out they're pregnant, they should, they should gather up their team and maybe even bring their doula with them to the doctor. I know when I was pregnant, and I just had your basic obstetrician, OBGYN doctor and such, and the whole idea of having a doula was kind of like a new age thing. This was 20 years ago when I first became a mom. So it's really interesting that how can we maybe help normalize this, or help people to realize, and anybody who wants to answer, either Teddy or Tyler, in your reporting, how can we make people aware? Because that's the whole point of this. I think people, they're just not aware that stuff like this is available to them.
We did speak to lawmakers during the process of reporting this story. And, one of the things we heard from several on both the Republican side and the Democratic side is that, there were ongoing efforts to try to look at ways to incorporate doulas and other parts of a larger medical team, be it midwives or other options, into sort of insurance coverage, be it Medicaid or other types. And so there definitely is a greater understanding that some women choose this form of advocacy as a way to help them through their pregnancy. And just to underscore, one thing that Kira has mentioned several times is this notion of sort of medical advocacy that goes back to an underlying problem here, which is that, again and again, women aren't listened to in the medical establishment when it comes to pregnancy-related issues. And I think no clearer is this laid out than in the federal, CDC's Hear Her campaign, which is all about trying to promote the idea that medical professionals need to do a much better job listening to women in an effort to try to reduce some of these pregnancy-related illnesses, injuries, and deaths.
Very good. I'm going to jump to a couple of questions that we received right after the series published. There were some email questions. One I'm going to pass over to Teddy. Just looking through my notes here, and just bear with me for a second to find my notes on the question. But the question off the top of my head had to do with sort of I think we kind of touched upon this a little bit, but just if you can just expand a little bit, Teddy, about one of the questions was like during preconception and interconception. So interconception is in between births to kind of improve outcomes and such. So you had some thoughts on that, Teddy?
Yeah, and I think it's a really good question, and kind of a question that Tyler and I had when we started this reporting is like what aren't we doing? Like how can we make this better? And I think, one easy answer that or more straightforward answer that we came across was, vaccinations are a really important part of this. We saw during the pandemic that there were lots of, pregnant women in the ICU from COVID complications. Pregnancy puts you at a higher risk of developing these complications. So making sure those vaccines and COVID treatments are, readily accessible, is a straightforward way that we can, help reduce maternal mortality. But like other than that, there is really not a silver bullet to solve this
Right.
issue, which I think is something that everyone has touched on here. A lot of our sources talked about bigger systemic changes, like this is the canary in the coal mine, and we have to really sort of like overhaul the healthcare system to get to the root of the problem. So Medicaid expansion is expected to really be beneficial for this problem. Taking steps to reduce systemic racism in the healthcare system. And then, as you guys have talked about, improving access to doula services is something that we can do.
Right. Well, that was the next question I was going to ask. Someone had already emailed a question about Medicaid expansion and related coverage, and supplemental care, such as doula. So we've kind of talked about that. I think more than half of infants born in North Carolina are mothers who are on Medicaid. Kira, do you have anything to add about that? How that would help? How that could help? I know there's a discussion about whether or not doulas should be regulated. I don't want to get too deep in the weeds on that question, but I think that's something that has come up. Another colleague of mine wrote about that, whether or not that's a good thing or a bad thing to like regulate doulas so they can be more under Medicaid coverage. Do you have any thoughts on that, Kira?
I think regulating doulas would not do much to improve birth outcomes. If we already have a broken system, pulling doulas into a system and then regulating them, telling them how they need to practice, it's probably not going to produce better outcomes. One of the things that makes birth outcomes better with doulas is that we're not part of the medical team, that we are there working with the families however they need us to show up. And that's a lot of times when you do regulation, you have one size fits all. And that's not the case with birth. It really depends on each family that we work with. And doulas need the freedom to be able to assess the family needs and then address them individually. And then, medical does, when you were talking about insurance and Medicaid,
right.
they operate in a way where we're billing for services. And so it's not a billable service. Going to someone's house, rubbing their shoulder, making them some tea and having a conversation is not it's not billable.
Right.
And so it'd be really hard for doulas to do the things that we need to do and support families in the way that they need us to show up, and then kind of classify it under whatever code they want to give it as an insurance item. One thing that we need to make sure that when we had talked a little bit about seeing women as victims and portraying them as victims that need to be saved, that's a lot of times happens with pregnancy. Women don't need to be saved from pregnancy. That we don't need anyone to come in and rescue us from this dangerous medical condition. What we need is for the system to change itself so that it can stop harming the women that are in it. We need the women to really value the women and their voices and trust them in making decisions and not kind of steamrolling them and telling them and bullying them into doing what others think is best for them, and trust them to know that they're the experts on their own body and being able to make sound decisions.
Right. I guess the whole conversation about making doulas under insurance or Medicaid available is because, there's services that are offered, but they cost money. Like,
Not always. We have lots of volunteer doulas. There are always. It's not that there are doulas that are unaccessible. Doula support is accessible. We have volunteer organizations where doulas volunteer their time. We have doulas at all different price points, and so it's really just a matter of being able to access that information. Where can we find doulas, as opposed to we can't afford them. That's an assumption that a lot of people make. But there are doulas all over the price range and even to free.
Very good. Okay, I'm going to open it up to some questions that were submitted online. There was a question here from Angelica Simmons on Facebook, and she was talking about Richmond Memorial here in Richmond County, a few miles from Mecklenburg County. They closed their maternity ward. And women have to now drive 30 to 40 minutes, obviously, which we've been talking about. That's part of the problem, that they don't have access, they don't have transportation. So I was gonna, and why is this? So I was gonna toss that to Teddy to start, but Kira or Tyler, if you want to chime in after Teddy, that would be great. Go ahead.
Yeah. So I think, part of the reason that these sections of the hospitals are closing is like economics. So, I mean, just a lot of births are paid, are paid for through Medicaid, and the reimbursement rates for, these services are just low. So if a hospital is struggling, that might be, the first thing that they close down. But another part of this is, it's really difficult to recruit OBGYNs to, many of these areas. So I recently spoke with, a practicing OBGYN near one of these maternity deserts, not quite in one, but she said, she could have job postings for an OBGYN for like a year or upwards of a year sometimes. She said it's hard to convince people to come to an area that doesn't have a target, and I think it's important to talk about this also in terms of the new abortion restrictions that we have in North Carolina. Okay. So not only is that making, experts say that this will make birth more dangerous, there'd be a lot more unwanted pregnancies, but it's also going to make it more difficult to recruit OBGYNs. A lot of doctors have concerns about, practicing in a state where, they can't provide the full range of services that they, have been trained to provide. So I think that is definitely an issue that has been on a lot of experts' minds.
Wow. Yeah, the whole issue of abortion rights and stuff is very contentious and such. And, when do you bring in morality with something like this? When is that a point to bring up? Kira, did you have anything to add about the Ms. Simmons' question? If you did.
Yeah, we do see maternity health, labor and delivery units closing down. We just lost Davis Regional, which was our supporting hospital to the only birth center we have in this area, which is in Statesville. And so when we are giving fewer choices for fewer birth options for women that are already having these challenges, if our only birth center is not even in Mecklenburg County, if you don't have transportation, that eliminates that as an option. You don't have an option for an out-of-hospital birth. And when you're looking at statistics about where you would feel safest, you might not feel safest in the hospital, and that's your only choice if you don't have transportation to the birth center that is kind of far away.
So just to kind of recap, because I think we've covered a lot of territory here, just in terms of just some solutions for our viewers that are listening out there, just in terms of, we talked a lot about what we can do before conception. We talked about what we can do in between births and stuff, and vaccinations, and to maybe consider getting a doula. And there are doulas available on various price points, as you mentioned, or volunteer doulas. So that's very encouraging and stuff. But is there just anything else you guys want to add, or that we missed, or anything that you might have wanted to see more of, Kira? Because we're going to be out there still covering it, but you're the professional, that's in the trenches out there seeing seeing everything. So what would you want to see? What kind of solutions in that? What would you like to see change?
I would like to see more of I'd like to see more involvement with healthcare professionals that are addressing maternal mortality. And one way to do that is yes, making sure we have access to doulas, but that's outside of the hospital. I want to see more inside hospital stuff doing. What are we doing to make sure that we are addressing what's going on culturally within this hospital system, really making sure that we're looking at policies and making sure that we're making it easier for patients to access support and not making it harder. You know, doulas, that's one way. We are trained non-medical professionals that provide support, emotional support, physical support to our patients. But we want patients to be able to decide what that support looks like, even if it's not a doula. If they want to have their best friend there, or they feel more comfortable with their aunt or a cousin or whoever it is, that they get to choose what their support team is going to look like, and that they have access to that support team while they're in the hospital. It's already scary going into this, but understanding that, yes, when I go in, at no point will I be separated from the people that I trust. And, you know, that the people that I've either hired to protect me, or a birth companion that I choose to be with me, is also going to not be separated from me. Will they pull me back behind a curtain somewhere? And so in order to do that, we really need to trust women in choosing their support team and not trying to regulate who they pick to provide that support to them.
Right. Thank you. Tyler, do you have final words to add?
Yeah, I mean, I think one thing we're really going to be watching closely is what's going to happen to these numbers that we've reported on over the next couple of years. I mean, we've already touched on that, you know, these data points that we've looked at are already a couple of years old. As we touched on in the stories we wrote, we've got some preliminary data that's looking at the fact that the number of pregnancy-related deaths has gone down slightly relative to a peak in 2021. But even that data is from 2022. And quite frankly, even during our reporting process, that number fluctuated a little bit as state health officials adjusted it. So, I mean, I think, you know, we, as Teddy also mentioned, you know, COVID, obviously a major driver of this increase in maternal mortality and pregnancy-related deaths. But, you know, we haven't gotten back to where we were before COVID. And even before COVID in North Carolina, the numbers were trending up. So, you know, what's going to happen over the next couple of years as a result of expanded Medicaid, as a result of money coming in from this abortion bill that both included some measures to expand Medicaid reimbursement rates and other things experts feel would help in combination with doing things like restricting abortions, which experts think are going to hurt. You know, what is the net effect of that going to be? We're going to be looking at that very closely.
Very good, very good. Well, it sounds like there's a lot to cover, a lot for us to continue following over the next couple of years, especially in terms of from an accountability standpoint, to see if the numbers are changing or if some of the solutions that were presented out here can actually make a difference in our community. And so I want to thank everybody for joining us on our continuing conversation on this series. If you did not read the series, it is on our website, the charlotteobserver.com or the newsandobserver.com. And I want to thank our guests. I want a special guest to Kira Kimball for lending her expertise and her experience to this panel, and Tyler Dukes and Teddy Rosenbluth. Thank you very much for your reporting, and we appreciate it on behalf of the Charlotte Observer and News and Observer. Thank you very much for tuning in. A recast of this, I think, should be available on the website. I'm not 100% sure of that, but I'm just going to toss that out there anyway. Thank you very much for coming, everyone, and have a good afternoon.